So the audience was, the panel was very good at submitting some very timely questions, most of which I'm going to throw open to all the panelists. So let's start with Mon. So if you could concisely, and this is for the rest of the panel as well, what was your organization's first foray into AI, and what was done to try to ensure that it would be both adoptive and sustained, rather than an interesting project that just didn't work out?
Well, thank you, and thank you, Ransel and C3, for having us yet again. I told Ransel this morning, this is my favorite time of the year, when I get to come to New York and I get to participate in this nice summit. A couple of years ago, we were all in Bahrain, and part of this session was about AI. And it seemed, although we've been working on AI, we've been talking about AI in my own organization at the Cleveland Clinic, but it seemed conceptual at the time. It seemed like a little bit of a concept as opposed to a reality, and we were all trying to imagine what would it look like once we were there. And today, I've been giving lectures on this. We're already in AI. We're knee-deep into AI, and it has transformed the way we practice medicine, at least. And when we talk about AI, it's important to realize that we're talking about different things. We're talking about AI from an administrative standpoint, from a large language model, which I can tell you, since we went to the electronic medical record, this is the second revolution in medicine, because now I can actually get a note as I'm leaving the room. I never type a word into the chart. It's all summarized. It's on my iPhone or iPad. I walk into the room. I tell the patient that I have my assistant in the room, and the note is summarized, and it's better than I ever could. So that's saving at least 2 to 3 hours of extra work for any clinician in our hospital today. By the same time, AI is also working with our research colleagues, and they're doing amazing things with AI. And we published, just as an example, we published a study about the risk predictive models, and it turns out that the machine learning is better than any other models that we've used in the past, and it's sort of changing the way we look at risk prediction in cardiovascular medicine. The third thing, which I'm learning from my colleagues, is the implementation of AI into the day-to-day operations of the hospital. And just to give a quick example, our colleagues in MRI and imaging, now they're using AI to protocol the studies, which a study used to take an hour, for instance. It's now taking 25 minutes. So you can just imagine the throughput and the efficiency that AI is providing. I was in the UK last week, and in the NHS system, their target for radiation therapy is 85% at 60 days. They can only do about 35 to 40% of radiation therapy. And it turns out that because it takes a lot of effort to protocol those patients and to get them through the system, AI is the solution for this. So this is when I say we're talking about too many things at the same time, but we're already there. So there's no going back. It's no longer conceptual.
Great. Ahmad?
Thank you, Dr. Michael, for being moderator for this session, and thank you so much for having me today. So actually introducing AI organization has been a journey. Today we received, for example, an email from Organ Transplant Center of Excellence in the hospital with 4 proposals to implement AI for 4 different business purposes, with a quantified need, quantified impact. But was it the case like 5 years ago? 5.5 years ago, well, COVID was Q4, almost 2019. At that time, we were just after clinicians, please, let's consider AI. And no one wanted to work on that, literally. No one would just leave me. I know my job. I don't want to help from AI and technology. And things shifted now that we cannot handle the amount of proposals that we receive for applied AI. But is it really the purpose to use AI?
How did you overcome that?
Actually,
hesitancy?
we moved from just like, to start with, actually, to change the culture in the hospital, we introduced a couple of AI projects, and we were very focused on making them successful. And one of them was COVID-19 platform that managed the hospital during COVID-19 crisis in terms of supplies, number of patients, cost, clinics that should be shut down and moved to COVID-19 clinics, etc. And that one of the things that actually changed the culture, and people started saying, AI might work for my hospital, so please, can you implement it in our department? And we started really doing like just minor projects here and there in all departments. And then we moved into the full ecosystem, that we call the Innovation Hub ecosystem, that has the governance, and the governance is not just about the safety of the AI model, it's about the selection of the AI project you want to implement in the hospital. So does it have value? And that comes, sustainability is the key word for this one. If it is not linked to a business problem, if it's not linked to a need in the hospital, if it's not linked to some clinician actions that will be done after the AI makes its prediction, if it is not linked to success metrics that you monitor over time, it will fail. And we had multiple that failed, actually, because of that. So sustainability is a crucial aspect of this. So, and I would say, like, actually, AI became actually a natural progress in healthcare. It's not really, I would say, something new. And there will be other tools than AI. Now, with the increase of population in all these cities, the pressure on the healthcare service increase, patient expectations are different now. I call it like patient 2.0 experience. Expectations are very different. Patient 2.0, allow me, excuse me if the microphone is. Patient 2.0 experience, they don't expect like to waste one full day or just take a day off from work for a 5-minute appointment for the doctor to tell him, you know what, your results are good. You can just like leave. That's like, I took a full day for that. A 2-hour commute, 3-hour waiting time, etc. The patients now, they Google their symptoms, they talk to this online tool before they come to the doctor. So their first opinion, the primary doctor, becomes second, actually. And they challenge the doctor. Now, the expectations from doctors are also different. They expect doctors to generate revenue, expect doctors to see more patients, review tons of medical charts. You expect doctors to make no mistakes and publish papers and maintain life-work balance. So that's why actually what the healthcare system has started looking for, you know what, is there anything else, anything here that can help us? And that's what we looked for AI. So we moved really from organization that was against applied AI in the organization to now we have almost more than 30 applied AI, statistical machine learning, clinically validated, including like 5 AI agents, generative AI, large language models in the organization, and tens in the pipelines. So it was such a journey actually between, and I think everything started in COVID-19, just before COVID-19 hit the market.
David?
One of the things that we learned early on is that the staff had to be very enthusiastic about AI projects. And so something came up where we realized that we were underdiagnosing malnutrition in a very serious way. We looked and we saw that we were only finding severe malnutrition in about 3% of the patients at Mount Sinai Hospital, and many of our peers were really much higher. They were up around 10, 11%. So what we did was we created a predictive model that worked with the work lists within the electronic record and sent the dietitians in descending order of likelihood. And we tripled the rate of diagnosis and, of course, tripled the rate of treatment. And the nice part about it is in this entry-level task, if you want to think of it that way, the dietitian gave us a thumbs up or a thumbs down on every prediction. And so they felt very much in control, and their job satisfaction improved because they didn't become dietitians to go and not make the diagnosis and not to treat people. And so it was a very positive thing, and then it went on, and clinical deterioration, identification of patients who are likely to have delirium, And we currently have about 20 use cases in active production. And in all cases, we learned something very important when the electronic health record company tried to introduce a sepsis algorithm. It didn't work at all in our patient population. We ran it in the background and we said, this isn't good for us. And so I like to use the phrase, well, the Americans, the audience probably recognize that old cliche, all politics is local. And what I've tried to say with the team is all predictive analytics is local. So if we take that attitude and put the workflow and we put the staff in the forefront, then I think we will achieve great success. And every organization has to follow its own journey. And I think that's the main message that I'd like to give people is let your staff show you the journey.
Yeah, it's a kind of analogous to have the workers on the machine floor suggest how to do things better. So for better or for worse with the U.S. healthcare system, two major factors involve regulation and reimbursement. So just touch on one, then we'll get to the other. But Charlene, in your opinion, the current regulatory climate in the U.S., how is it impacting, for good or for, is it stifling innovation or helping nurture it?
Both. The regulatory environment, as I think many of you who have to operate in the compliance space would know, is very fragmented right now. So you've got hospitals and other healthcare providers who are dealing with state and federal regulations, some that conflict, even conflicting regulations across different agencies. And we have a lot of obligations in terms of compliance to different agencies, whether it's CMS or OCR. And so there has been for the several years that AI has been important, and I think that COVID-19 sort of, the end of the pandemic as we came out of that really is a good demarcation point, but sort of as that adoption became more prevalent, the Federation of American Hospitals has been advocating for a single unified AI framework so that everybody would understand the rules of the game and how we're operating and would not be faced, that would supersede any state laws that go further or do not go as far in some cases. But we don't have that yet. And so I think that does contribute to the hesitancy of some health systems to make investments in AI. On the other hand, we don't have over-regulation yet in this area either. So we're seeing a lot of different opportunities for players in the healthcare space, hospitals of course, but others as well, to really experiment with new technologies and figure out sort of where we're going. And that's, we do want to encourage that. We want although we want a regulatory framework, we want that to serve not as brakes on innovation, but as true guardrails that will allow us to keep going ahead to implement some of the ideas and innovations that my colleagues have talked about here.
So as an organization, to follow up on the regulation side, so the current administration is for, in general, 50,000 foot less regulation. So as an association, just an important one with the American hospital system, how do you balance seeing the positives of how it could provide less impediments to innovation while still make sure that you could say the hospitals, your members, are protected from any legal consequences of the lack of regulation?
So there's a lot of noise in Washington right now, so there's probably not a lot of conversation about what the administration is doing or what the agencies are doing that's sort of reaching the general public. But I think there are some important steps underway. The FDA is looking at different approval processes for AI-informed devices, and those are important for our members to know what they can trust and what they can use. And there are other areas in which we see bipartisan interest in this growing, and so we're encouraged by that. I would say that, with respect to liability, that is a major concern that has not yet been addressed, and most of the liabilities laws in the U.S. happen at the state level, and we have frameworks for other parts of the industry. So if you look at medical devices, if a medical device goes wrong, there's case law that dictates how that is treated in a courtroom. We don't have the same kind of framework to apply to clinical decision-making where AI is employed. And so we do believe that it's important that manufacturers take responsibility for tools that may go wrong or may be biased or informed by bad data.
Please.
Yeah, if I could. One of the things that has been very important to many of us is on the hospital side is to have a seat at the table as these regulations evolve. And the Consortium for Healthcare AI, which was formed in the U.S., it involves many organizations here, in this room. And I believe it's going to set up, if it works out well, it sets up a series of assurance labs. So think of it as a way of distributing quality assurance for AI products among many organizations around the nation that put in the effort to qualify to become that. And I don't want to say too much more about it, except that, I think Mount Sinai, I'm sure Cleveland, many of the organizations around the room will be interested in that process. Interestingly, Joint Commission also just started putting together certain regulations that will probably come into standards in the not-too-distant future. So I think the most important thing to take away from this is that just as we work with our advocacy organizations at the state and the federal level to help us, advocate with governmental organizations, we want to make sure we're not regulated out of existence before we exist, and we want to assure that the public is protected and that the products that come out are of the highest possible quality. And exactly as you said before, I want to come back to bias. We see in the patients of East Harlem, where the main campus or the main hospital of Mount Sinai is located, that some of the out-of-the-box prediction models I referred to sepsis before just didn't work. So you have to be very, very cautious. And we just even published a paper on this, that we feel that it's very important that as we develop the local models, that everyone keep their local population and the potential biases that algorithms could introduce at top of mind. The best way to have accuracy, and the final thing I'll say on this point, is that every doctor, every nurse in the room and that is using AI has a license, and their license is at stake. So our job is to make their work better and not to introduce more pain and more errors and obviously bad patient outcomes.
Please.
Those are great points. I think it's yet another example where the technology is ahead of the regulation and much faster is going, and it's being commercialized and it's being offered to places like our place, like Mount Sinai and all the hospitals in the U.S. And it's up to us to decide where to implement it, how to implement it, and how safe it is. And I can relate to the issue of all AI is local. Whenever we wanted to publish our own paper, we were kind of concerned because it kind of changed the paradigm, like I said, for cardiac risk prediction for liver transplant patients, just to give a very narrow example. So we're learning as we go before we even get into the litigation issues, which I've not heard too many yet, litigation about those notes that are being generated by an AI scribe, let alone the new algorithms that will be complied or put together by AI. I think the future is a little bit unclear because we're going at a very, very fast pace. One more thing that I would say about the risks, there are already some publications about the de-skilling aspect of AI. So when a radiologist or when a physician starts to recognize an ailment, a visual ailment, and starts to rely on AI increasingly, now they're looking at those physicians or healthcare practitioners and they're saying, you know what, once you start to rely too much on AI, your skills are starting to degrade, and there will be an issue related to this. I think it's a very exciting time, personally. I don't think we can live without AI anymore, but it's transforming healthcare as we see it. We haven't even touched on the issue of the workforce and how it will have a major and severe impact on the economics of healthcare.
Please.
So I feel like it's the governance and regulations is actually a crucial thing here. Is that as like here, technology is way ahead of regulations, and we are facing this in Saudi Arabia. We're growing. Just recently, like 2 weeks ago, I realized that actually there's a section in JCI accreditation that's what just added for the hospital accreditation about AI and how AI should be monitored and implemented and the impact of it is being measured. So the hospital accreditation now is under pressure like that. And there's other regulations as well in Saudi Arabia that being created by SADAI, Saudi Data and AI Authority, and the Saudi FDA approvals as well, clearance. So, and we have to go through all these regulations, and I can assure you, even if you go through all of them, doesn't mean that the AI is safe. So still, you have to do, like, for every single system that you purchase or develop in the hospital or by your research center, it has to go through technical review, it has to go through clinical review validation, and it must have a continuous monitoring process. And that's, like, actually crucial. And that's what sometimes the end user or the stakeholders, they don't realize. They realize that, you know what, I have time to build an AI system, but I don't have time to every 3 months to look at the results and tell you, you know what, we need to fix it. Have been, like, the performance have been drifting, or it's not working fine, etc. So we notice actually that native AI applications are required. Integration between the digital IT strategy is required. The engagement of the end users, clinicians, they don't have protected time to work with you, like, on building AI systems. And that was a big challenge, actually. So we need to be sure, actually, if we engage them the right way, that doesn't really just add extra burden on them. Instead of helping them, we are actually hurting them. The other items about actually all data or all AI is local, just last one, is the challenge we're facing now with the startups. Startups now, look, we have startups coming from the US to Saudi Arabia, or other way. These startups are trained on US data. And the performance of the model, they will show you, look, I have tested my system in hospital X, Y, Z of the top hospitals, and the performance have been what? Beautiful. It's like really, but when we tested it in the hospital, it reached 60%. We could not exceed 60%. So that's, like, actually requires retraining on the local data population. And this was, for example, a model for predicting breast cancer, patients who are going to predict breast cancer in 5 years. That was actually, it didn't show really high results. And that's, although it showed great results in other hospitals. So I think, like, this regulation thing in the governance is a really crucial aspect. It's growing as we go, and it's different from one place to another. That's
Right.
actually create another layer of complexity.
So some of you touched on risk, and that's something I want to circle back to Charlene about. And that is, so let's say you have a member hospital, smaller one, maybe community, hospital, rural. What are some of the potential risks and possible unintended consequences that your organization might discuss with them so that, when they beta test something, when they dip a toe in the water, it's successful and sustainable? So
just for legal protection, we don't advise our members on operations. But I will say for the small rural hospitals relative to a Mount Sinai or a larger system anywhere that we represent, they're going to face different risks with AI. And the first one, of course, is that they don't have the resources to adopt the same technologies that larger systems do, of course. I think longer term, as we think about reimbursement policy and how that factors in AI, you have potentially even bigger disparities, whether that is a reimbursement policy that accounts for the time a clinician takes, and that time is sped up when they have the right AI tools, but the rural system doesn't have those tools. So is their payment not going to cover the cost of delivering care? I think there's a real risk that we exacerbate those disparities between small rural or even underserved urban hospitals and their larger and more well-resourced counterparts. The flip side of the risk that I would say is hospitals are obviously not the only ones in the healthcare system that are adopting AI. And so we saw early on insurers who were very enthusiastic about leveraging AI technologies for claims adjudication. And there's a ton of risk in that. And when we think about, if you look at particularly Medicare Advantage plans relative to Medicare fee-for-service, claims denials rates in Medicare Advantage are significantly higher. And it's not necessarily justified. So when you have an AI tool that's built around a system that has historically functioned in a way that is not entirely compliant, there's a real danger that tool is going to learn the wrong behaviors and that it becomes even more complicated and administratively costly for providers to fight those claims.
Please, David.
Add to that, this is a question that I get asked from time to time as well, because not everyone is, the scale of these massive health systems. even though it does seem that they seem to be growing all the time. But if you're in a small hospital and you're using one of the electronic health records that is starting to build AI products into their core deliverables, I think that's a very safe way to enter into the space. But the piece that has to be done locally is creating a governance structure to assure quality, avoid bias, and to monitor implementation and assure good workflow, et cetera. And so that's I think the challenge, and I would encourage people to emulate. And I would think that the federation, that you represent, Charlene, and also AHA and other key organizations could help to create templates for governance structures for AI, which would have to be done locally. I imagine you could potentially outsource with some consultant services, but I think in the long run, it's best because of the ubiquitous nature of AI in the not too distant future to develop that talent locally.
Please.
Well, I don't practice in a small hospital, so it's very hard for me to grasp the difficulties, the enormous difficulties that they have to go through on a day-to-day basis. But I can only imagine that delivery of care is becoming much more expensive, and there are not enough practitioners. And so I can imagine that AI will probably come in to solve some of those problems by networking with larger organizations such as Mount Sinai, perhaps Mayo Clinic, or some others where you can provide care to the local population with less workforce. So I can imagine that this is another area where AI is going to be helping. I was just very happy to hear when General Petraeus was talking about him not needing a speechwriter anymore. There's a lot of things that we're doing with AI now that we kind of hush in the hospital, but I think it's prime time right now to go into those directions and just unleash the capabilities of AI.
So, Ahmad, I want to start with you, and others can chime in specifically about responsible governance of AI. Why do you feel it's so important? And at your particular institution, who has the responsibility for the governance of implemented AI?
Okay, this is actually an area that's like a very high, it's a critical component actually of AI work. It's like, and also we have two kinds of governance. We have a governance that reports directly to the CEO, and that's actually take care of the data governance and the AI governance to ensure that actually matches the regulations, whether the national regulations or JCI or FDA approval, etc., and plus the appropriate responsible AI policy in the hospital. So that's actually outside of the execution team, which builds the AI systems. These are two different teams. So, and we wanted to really intentionally make it separate, so actually one can govern the other, one can do the risk assessment of the execution team. That's one component. The other thing, actually, inside the implementation team, we have the multiple factors for governance. So, some of the factors about fairness, and that fairness actually does the AI address all the patient population or is targeting certain patients. I want adults, heart failure for adults, or heart failure for male or female, etc. And that's actually where we rely heavily on the clinicians to be part of this governance process, especially for testing. We have technical testing to ensure that technical factors of the AI model that says the accuracy, specificity, F-score, all these activities, we take care of it. But when it comes to the business, the clinicians, even if the model is high performance and the end user say, you know what, it doesn't work, then it doesn't work. With the final say with them. That's like then this one. And then like the fairness and then accountability. Accountability, I can tell you like about a model, about conversational AI model that we actually from a vendor-based solution, conversation for the patient. We wanted to give it to the patient to ask about their symptoms and their patient chart, etc. And I asked the clinician one question: who's going to be accountable if this AI agent give a wrong answer, wrong recommendation to the patient? And no one raised his hand. It's like, okay, let's, because actually the whole thing is about actually how we can give a better experience to the patient. But I want to be sure that if it gives the wrong answer, somebody should be accountable. Whose liability, etc. So all these actually aspects of the responsible AI governance are being discussed for every single AI model we talk about. And it might be simple from outside, like that, you know what, if we implement this system, it will take care of our problems. But actually, it's not. There's a lot of risks in implementing the wrong AI model in the organization. And it's expensive to maintain. So you better implement the right model from day one.
So how do you do, you could say, a cost-benefit analysis between this will save us this much time in, say, workflow, easy work,
Yes.
versus the cost of implementation and maintenance,
Yes,
training?
Exactly. I'll tell you one example that we received from radiology department. There was a case where we wanted to distinguish between classification model, distinguish between patients with pneumonia versus COVID-19. I want to look at the chest X-rays and say this is actually COVID-19 or pneumonia, and it actually impacts less than 0.5% of the patients. While we're doing the analysis, we found more than 30% of the images, chest X-rays, are normal images. So we told them, you know what, we can exclude these normal chest X-rays and tell you for high accuracy, these are normal chest X-rays, and you can give it to your junior, to fellows and residents to look at it and keep the suspicious stuff to the consultant and senior physicians, senior radiologists to look at it. That's the way, and they loved it. It's actually reduced their workload, enhanced the experience, and even for the junior doctors, they love it that they are given the chance to evaluate and validate the AI model. So that's actually, and every 3 months, we maintain the numbers. Have we are able to actually to enhance the service utilization of the radiology department? This is actually an example that we did face actually in the hospital.
So please, David.
Yeah, I think I love the example of what you gave. I think all of our organizations are different, have different strengths in different areas. And our School of Medicine had a data use committee. And, you know, they were using predictive analytics for research long before it became a clinical issue. And so tapping those resources who were experts in data cleansing and quality was very important for us. But making sure that, you know, they didn't, you know, rule hospitals, as it were, because their needs and their philosophy about data use was quite different, and they were interested in, you know, maintaining a level of security, for example. And so what we ended up doing was finding people who were most fascinated by data use for clinical operations, for background, you know, business operations, and other aspects of running a large organization, a large healthcare organization. A group that was interested in frankly, the finance. And so when we put all those different groups together, they formed the 4 pillars of what became our data use strategy. And I would think everyone should keep in mind that they have to, you know, remember there's clinical, there's operational, there may be research if it's a research organization. And as long as you live within those paradigms and create those work groups, and then have, obviously you need an executive leadership, it naturally falls into place, I would say.
You ask about the economics and how do we calculate the return on investment, or I think it's still not clear. I mentioned earlier that we are seeing the reduced time to perform an MRI, for instance, or any imaging study. There will be implementation for reporting, and all this is saving time for the clinician and for the system. The real question is, will the system demand more from the practitioners, or will it be sufficient? So in other words, will there be an improved in work-life balance for those practitioners, or is the system going to demand more because of the increased potential revenue that is generated by AI?
I think one of the important questions that our health systems are asking is what's the problem that we're trying to solve? You know, particularly as investor-owned hospitals, they have to think about the purpose of the investments that they're making. And so as they look at AI, I think the first thing that they did was to look at administrative burden and some of those back office processes that are really contributing to provider burnout on the one hand, there's staffing shortages on the other, 2 sides of the same coin. So how can AI come in and address those issues? And so they're looking at things like shift changes. Nurses come in, they spend 45 minutes of an 8-hour shift working on charting and doing that handover. How much can you speed that up with an AI process? Not only speed up, but also attack an area that is rife with errors. So I think there's a lot of potential there to just cut down on the labor that's going into non-clinical work, and that is not what our clinicians want to be doing. It's really what drives the burnout trends and thus the workforce shortages. So I think there's a ton of potential there, not just from a cost perspective, but from improving the clinical operations as well.
I'm going to sneak in one more word since I've got a distracted moderator for a second. And that is, I'll just going to give one example. We often are so obsessed with ROI, and I believe finding the ROI and making sure you don't have death by pilot are two very important things. But consider sepsis for a moment. If we do a better job of identifying, treating sepsis, people survive sepsis and they spend a long time in the hospital. We actually lose money on patients in our American healthcare system who spend a long time in the hospital because of the DRG system. So it isn't return on investment, it's a value that is achieved because we went into healthcare to save lives. And sometimes we will have a use case that will help us economically, and sometimes we'll have a use case that will help us clinically. And so I think it's very important that we have a very flexible approach to identifying the value that we achieve.
Great.
Yeah, very quickly, because we're out of time. You can have the last word, but very quickly.
Oh, thank you. I appreciate it. Actually, I would just basically echo what they said. We noticed over the 5 years experience in applied AI, the 3 areas we found actually that very crucial: operational intelligence. With the focus of that, actually remove the noise around the clinician. And if we found actually if we take care of the clinician, the healthcare system, care quality will automatically be enhanced. And including, for example, auto-generation of discharge summaries, patient chart summarization. I would like quickly this to be automated, generated, and give it to the doctor to validate, et cetera, et cetera. Now, the second one is the patient journey analysis. We look actually at the patient experience. Well, I should not limit it to patient. Actually, all the stakeholders of the hospital experience, including using AI to plot the patient journey. We have in one clinic, the doctor was expecting the patient journey to be 1, 2, 3, 4, 5. When we looked at the data and plotted for him in real time, some patients actually going into loops. And that's actually why some of them submit like this bad surveys, bad breast gain satisfaction surveys. And third area is basically as Doctor mentioned, the care quality or the focus on the clinical outcomes. Diagnostic number 1, and then preventive, and then prognostic. For example, prognostic, now we're working on a model for BMT patient, bone marrow transplant. If we can predict that the patient most likely will have an excellent prognosis, maybe we can actually put him back to home with a controlled environment and save this 30-day room that most likely he will need after the BMT for another patient. So I think AI has successes, but at the same time, a lot of risks, and we just need to be sure where to use it.
Well, thank you. And as one day maybe a patient, it's comforting to know that instead of just being amazed with the new technology, that all your organizations are keeping an eye on things like governance and adoption and access, and that's very important. So thank you for your attention, and thank you to the panel.
I appreciate it.